Good morning, everyone. My name is Deepa Rao. I'm the current president of ABO. Today, we have with us Dr. Kamala Audury and Mrs. Pushpalatha Venkataraman. Today's session is postpartum depression. Postpartum depression is also called PPD, is a serious medical condition that affects many women after childbirth. Many of them ignore these strong feelings of emotions and anxiety. Dr. Kamala, psychiatrist, and Pushpalatha Venkataraman is a physician assistant in psychiatry, will be discussing this issue. Dr. Kamala Audury is the founder and CEO of the Center for Behavioral Health and Sleep Disorders in Medina. It's a private practice clinic focused on helping people with mental health and sleep problems. Dr. Audury has always felt a connection to people with mental health disorders. She did her medical schooling at Veer Surendra Medical College in India. After that, she came to the United States and hung on her dreams to pursue her career. The decision to specialize in psychiatry came with ease. As she was doing her residency in psychiatry at Cleveland Clinic, she was intrigued by the intricate and bi-directional connection between mental health and sleep. These interests led Dr. Audury to pursue a fellowship in sleep medicine at Cleveland Clinic. After her fellowship, she continued to work with people with comorbid mental health and sleep disorders at Cleveland Clinic, Akron General, CCAG. Before we move on, we want to let you know about ABO. ABO is a 501c3 nonprofit organization for Asian Indian women promoting professional development and education through scholarship and cultural outreach programs. We aim to foster and support women for personal and professional advancement while providing volunteering opportunities. ABO promotes culture and education while establishing productive social networks for women. ABO Helpline has played a pivotal role in helping women improve their lives. Over the years, it has helped many women in situations of domestic abuse, financial distress, and navigating immigration law challenges. If you or someone you know is a victim of domestic violence or is being subjected to abusive tactics of power control, call ABO's helpline at 440-218-6965. Someone will get in touch with you within 24 hours. Your call is strictly confidential. Now let's move on to our session. Thank you.
Deepa, did you make me the host?
I'll make
you. Okay. Okay.
Good morning, everyone. It's a pleasure for us to have Dr. Kamala Audury with us, who is going to discuss with us what postpartum depression is and how to give more knowledge about into the postpartum depression, how we can prevent it, what are the methods we can go for the treatment, and what are the support system we can have for that one. And as we have already heard from Deepa Rao, she is double certified in the psychiatry and sleep medicine. She is also going to talk to us about the sleep, how it is going to help the pregnant ladies, how it is going to help with their depression. Welcome to the Zoom session now, Dr. Kamala Audury. Can you initially welcome to the Zoom session, and can you tell us little bit, can you tell us more about what this postpartum depression is? and how generally when we hear about the pregnancy, we just think about, oh, she's pregnant, everybody is happy, the new baby is coming to the house, and how we can get ready. Everybody will be thinking about the baby and how we can get ready about the baby. And what is more important about the lady and how we need to take care of the baby? Can we talk more about that?
It's such an important subject, Deepa, and you brought up a very sensitive topic here. Is yes, everybody is so looking forward to and happy to welcome the newborn. And what about the mother, right? In our olden days, and it's still applicable nowadays too, is when a woman has a child, childbirth. So not only a child gets a new life, but the woman, the mother, gets a second life. Because that's how precarious this part of um, um, her life is anything can happen. There are so many hurdles to cross throughout pregnancy and delivery and postpartum. So it really is a very crucial and crucial part of one's life, of an entire family's life. Um, and both mother and child need to be prioritized, right? Their lives need to be prioritized. What they're going through need to be prioritized. And woman being the pillar of the family, her health is of utmost importance. So we start off with what is postpartum state.
So,
So, so basically, postpartum state is the length of time or duration of time that it takes for all the organ systems in the body to come back to pre-pregnancy levels. So, and the guidelines give various durations, and for all practical purposes, I put down the first 12 months after delivery here. So now, what is postpartum depression, right? Um, so, so the postpartum depression is onset of the symptoms of depression within the first 6 weeks of delivery. Again, this might differ according to like what sort of guidelines we are following. Sometimes in some places it is 4 weeks, in some places it is 6 weeks, some places it could be a little bit longer. But for all practical purposes, onset of the symptoms of depression in the first 6 weeks of delivery. Now, why do we get this? Why do uh, why do people or women get postpartum depression, right? Really, the etiology is unknown. I mean, there is nothing set in stone as to the real reason, and there are all hypothetical reasons, all valuable reasons that we can hypothesize. They make sense. Genetics are one of them. Hormonal changes, which is huge. There is huge abrupt drop in the pregnancy hormones right after delivery. And some women can be vulnerable to how they react to that abrupt drop or switch in the hormones. And it's not known how, and there are some risk factors, obviously. However, it is really, you cannot pinpoint, like the exact reasons are not known. There is also a theory about the abrupt switch in hemodynamics. It's pregnancy is a state of hypervolemia, and right after delivery, there is an abrupt shift in the volume, the hemodynamics of the body, and that also plays a role. So several things. So so we move on to like uh, what are the symptoms of postpartum depression? So coming back to the onset, it's most commonly at least 50% of the cases of postpartum depression start in the first month of delivery. Then the symptoms are really similar to major depressive disorder that we find outside of postpartum or outside of pregnancy in just general population. The symptoms are similar to it. It's the onset of the symptoms that really differentiates in terms of symptomatology. So let's look at the symptoms. So these are like just saying that I'm depressed. It's not depression, right? It's a set of symptoms. And out of these that I have listed here, we look for like at least like 5 of those. One of them should include at least depressed mood or lack of interest. And symptoms more or less consistently happening over a period of 2 weeks. So the most important one, depressed mood. Then there is lack of interest, anhedonia, excess guilt or a sense of worthlessness. Oh, I'm no good. Oh, I should have had it together. Why am I feeling like this? I should have been happy. I just had a child. Why am I not feeling that way? Why am I not feeling fulfilled? All that. Why am I not feeling like doing much for my child or for my household? Why am I not feeling good? All that, the guilt and having to take a medical maternity leave and maybe foregoing a salary or something, that also puts additional pressure, like, oh, what am I doing? My maternity leave is going to end soon and I'm not able to do much, all that. So an impaired like concentration, not able to focus on much, suicidal ideations, that is also a symptom. Now, the other symptoms are mostly somatic, and I put them separately, and I'll tell you the reason why. The somatic symptoms, meaning the physical symptoms, are sleep, either it goes up or down, appetite, either it goes up or down, and mostly low energy. So these 3 symptoms can be seen just in general because of having a baby, going through all the changes and being tired because sleep is difficult, because there is a newborn, versus like happening in context to a depressive episode. So that is something, so we have to take that into the context. So if a person is just having some sleep issues, some appetite disturbance, some low energy, it doesn't automatically mean depression. There has to be a depressed mood or a lack of interest, and the other things like guilt and worthlessness and impaired concentration. A lot of the times people may not have suicidal ideations, but it still can be depression. So moving on to like, how do we know if we need help or not, right? So assessing the severity of the symptoms is very important. And the symptoms can be mild, moderate, or severe. It's very subjective. Even the criteria of depression itself is more or less subjective, right? So the severity can also be subjective, and some we can, when a patient presents to us, we kind of look and see, do a clinical correlation. It's called clinical correlation. So, so having suicidal ideations, suicide attempts, all that can also tell us about the severity. Now, there is so when I mention about suicidal ideation, suicide attempts, I don't want people to be scared about this. If we look at the prevalence, really, the risk of suicidal ideations or suicide attempts or even successful suicides, it is much less than the general population of women. So it's less. So that's a good thing, right? So however, if we have these thoughts, it's important that we notice it, that we not brush it aside, that we reflect on it, that we do something about it, because this can get worse, right? So so then another main thing here is intrusive thoughts. Intrusive thoughts are thoughts that come abruptly, all of a sudden. They're unacceptable. They cause a lot of distress. And those thoughts are or even visions, thoughts or visions of the mother harming her child. And this really takes us to another level with the depression. And it's very, very important that the mothers seek help for it. However, there is a lot of fear component to it. There is a lot of hesitation about telling this to near and dear or to medical professionals because there is concern that they might be put in the hospital or the child might be taken away from her, and these things are usually unacceptable, and it kind of gets caught a little bit late. But again, it's okay. It's okay. Confide in your near and dear at a minimum. You need the support. Postpartum women need this support. They need to loop in their family. So thoughts of harming infant. So it can mean either the depression has become worse, or it can also mean that there is some psychosis in there. So when we talk about this, there needs to be screening done for symptoms of psychosis, such as any hallucinations or any delusions, any any sort of like paranoid delusions that somebody is out to get the mother or the baby or something. There is the devil out, or anything like that. So those are the delusional thoughts when you reflect on it, you never had those thoughts before. At least, I mean, considering that this is first time postpartum depression with psychotic features, right? We know that it's important for us to understand that this is not normal.
So nice to hear about all these things. And I wanted to know, is it just, does it occur after the delivery, or does it happen before, during pregnancy, or is it how important it is for us to screen for depression during pregnancy?
So depression nowadays, it's coming to more and more limelight. Even though we screen for depression like a lot more than we used to in just general practice, even in a primary care's office, it's now being screened. Even then, it is still like missed or underdiagnosed, right? So every time, like during in the OBGYN's office, like there should just be a depression questionnaire for every visit. The first visit after delivery of the baby, there should just be a screening for depression. So not just a screening, Pushpa, there should also be education about it. Primary care, OBs, just in general, educated people, they should look up these things and they should educate themselves about these things, like the potential mothers, like pregnant women. Like, I would encourage them to just read up on these things, educate themselves that it's possible. Right. So a lot of the times the screening measures fail because patients don't report them correctly.
That is so true. And
Yes.
even I was reading that even during pregnancy, at least they need to be screened at least once for depression, which is not, generally they don't do it. At least they need to screen for depression at least once during pregnancy.
Yes. Yes, at least once, but I would just throw the questionnaire out every time. Right? I mean, it's usually like once a month appointment or something.
Mm-hmm.
This is a way to educate the patient, the potential mother, the pregnant woman, like, looking at the questionnaire. at some point, the understanding is better and better. There is no guidelines that are set in stone that you have to screen um, like an X number of times. Yeah, at least once is a very good place to start. But if you ask me, like every time, like when I go to my primary care's office, depending on which place I go to, they offer a depression questionnaire every time. Right. So, and those questionnaires should be encouraged to be completed. So sometimes people don't want to deal with it.
Yeah.
The key is in like, no, please finish it. Please complete it. If you need any help, let us know, is how the approach should be.
Yeah, and we talked about how what the postpartum depression is and what are the symptoms, what we need to observe when we have those, what are the symptoms and what how we need to be careful about them. What are the risk factors for those postpartum depression? Can we talk about that?
Yeah. So, um, so the risk factors, the most common risk factors is, like I said, the postpartum state of like the first 6 weeks. Then the other major risk factors are depression during pregnancy itself and a prior history of depression. So these are like very important risk factors, very common. So then there are other risk factors, difficult pregnancy, gestational diabetes or preeclampsia or multiple pregnancies or difficulty in delivery, some complications, C-sections, fetal distress or maternal distress or some other complications, hemorrhage or all that. Then health issues with newborns. If the newborn has some sort of a health issue that needs to be taken care of, or that needs a hospital admission or something, or even otherwise, that is a risk factor. Difficulty with breastfeeding, struggles with that, that causes some um, uh, uh, feelings of inadequacy. Oh, I'm not able to take care of my baby. Oh, I don't have enough nutrition in me to give to my baby. I'm not doing my job well. That sort of a self-talk that can happen. Psychosocioeconomic status is very, very important. Not having any support, single motherhood, um, not much money to go and, maybe hire someone to take care of your baby while you can go and just take some rest or just go and do something that you like. Financial state is very crucial. Then what not has the person been through, the mother has been through in the past? What traumatic events, what abuse, what partner violence, what which number marriage, or all those things can have an impact on the risk factors, right? They add to the risk factors. Body image issues is big. As we all know that after delivery, we magically don't look the same, right? Getting adjusted to that, to that new body, not hating ourselves over it, like, that's a risk factor. Family history of postpartum depression or family history of just depression, that is a risk factor. And there are several others like that. We can go on, so on and so forth, substance abuse, all that. So I hope that answers your question, Deepa.
Yeah, and can we talk about the other problems associated with the depression, anxiety, mood disorders, or you already spoke about the psychosis associated with depression. Do will the anxiety and mood disorders will they be associated with depression? Will it change the treatment?
So there is So there are some differential diagnoses here that we should consider when we are evaluating for postpartum depression. One is, I will start with postpartum blues, and that's very common. Most mothers have that in postpartum phase, and it's just feeling kind of down, and it's fairly self-limited. Um, and people are able to overcome and go on about their day. So that's there. Then there is, so then we come to the postpartum depression that we discussed about. Then how can it be like different from, there are other postpartum mental health issues that can happen. And one of them that I see in my clinic, it may not be mentioned so much in books, but it's just postpartum anxiety. As simple as that. Um, it's just anxiety or coming from the stress of going through all these changes, hormonal changes, you can call it what not changes, right? Going through the stress of all those changes from whichever direction causes this thoughts to act up, and just difficulty managing the stress. It may or may not affect the quality of life. It may or may not affect the day-to-day functioning. But anything that affects day-to-day functioning or quality of life would need attention. So there is a thing like postpartum anxiety without depression. But a lot of the times postpartum anxiety can be associated with depression.
Okay.
Right? And then there is psychosis that we already talked about. Now coming to a very important part, bipolar disorder. Now, there is if there is a history of bipolar disorder, meaning there have been symptoms of, there have been episodes of mania or hypomania. Which basically, manic episode is when people feel high on top of the world, or just with elevated mood, and having racing thoughts, pressured speech, distractibility, impulsivity, not needing sleep, a lot of energy and all that, all of them happening together at the same time for at least a few days. And if that has happened, and especially if that has needed, with or without treatment, whether it needed treatment or not, if there is a sometimes these episodes are underdiagnosed, they resolve by themselves, so there is no help sought or anything, but doesn't mean that that didn't happen, right? So, or the other scenario is that there could have been bipolar, like a diagnosed case of mania or hypomania. Hypomania are milder versions of manic episodes. So there could have been hypomania or mania, and treatment has been sought. So there is a documented history. So that actually can increase the risk of postpartum depression, having that history. So it is important to consider that in the differential diagnosis, and depending on how bad the manic episode was in the past. Like sometimes manic episodes can come with the symptoms of psychosis.
Yeah.
So it's important because the risk of mania also goes up in the postpartum phase if you have a previous history. So then we have to be careful as to what kind of medications we choose. It can have an impact on the medication management.
Yeah. And even when we see these symptoms, and even when we see but after the baby is born, even when there are so many obstacles for treatment, can we talk about the obstacles for treatment?
So there are a lot of obstacles. Tell me that a woman's life is all nice and easy and a bed of roses, right? And the obstacles only increase as the size of the family increases. Yeah. So there are socioeconomic obstacles, um, again, postpartum state, not working, not making the money, financially strapped, or single motherhood, not able to afford treatment or a copay or medication. That's there. Then the other obstacles are really like a lot of, like there is lack of awareness, right? So
Mm-hmm.
people are not aware that such a thing can happen to them. Sometimes we think that we are immune to bad things happening to us. It doesn't even come as a thought that, oh, you know what, that might happen, so I might read up on that or get myself educated on that or something, right? Lack of awareness. And then there is a dismissiveness. Oh, every mother goes through childbirth or whatever and postpartum phase. This mother in my neighborhood has done it. Why am I not able to do it? So let me just plow through. Dismissiveness, right? And there is stigma. Stigma is like, oh no, what will people think? They will think I'm crazy, or people will look down upon me, or my husband will look down upon me, or my mother or my mother-in-law will comment on me.
Yeah.
And
And
these are all legit reasons. There is a fear. There is a fear of seeking help. Fear that they might lose their child.
yeah,
Their child might be taken away, or they might be put in the hospital. All that.
yeah, yeah. And the other major thing is if I take the medication, it is going to affect my baby.
Oh my God, Deepa, you hit the nail on the head here. That is really important. That is very true. The fear of taking medication.
Yeah.
Yes, yes,
So we spoke about the symptoms, risk factors, and obstacles to treatment. And now comes the major thing, how we can, if we cross all the roads, now we are getting ready for when we get ready for the person to take the medications, what are the how we can treat them?
right. So, treatment is not necessarily medication. Treatment can start from like a psychosocial standpoint, right? If it is early on and if it is mild, manageable symptoms, then family can step up. Rope in the family, rope in the spouse, rope in friends, um, distribute labor, you
Mm-hmm.
know, or if you have the means, then hire people, make yourself comfortable, right? Um, uh, Pay attention to your needs, prioritize self-care, all that, making sure that you take prenatals through postpartum phase. That's very important. Taking care of your diet, eating healthy, um, not just ordering from McDonald's, like, avoiding junk food. Um, Taking the time to do a little bit of exercise, just a little bit, to just give yourself a break and just be able to relax. Those things by itself can help. And more or less high functioning people with mild severity. So
Yeah.
then we move on to like, okay, maybe there is certain other things that might help me. I might want to go to therapy,
Mm-hmm.
right? And because I do, like you pointed out rightly, like fear of taking the medication. I don't want to be on meds. It's okay. A lot of the times we respect that. We don't want uh, anybody to feel uncomfortable taking a medication. So these are all the options that we are looking at, not just medication options, right? So
Mm-hmm.
we look at, okay, oh, we have a counselor. Let's get you started with therapy. And that can work wonders. Just that little bit of support, being able to talk about yourself, learning some skills to manage stress, you know,
Mm-hmm.
be learning how to advocate for yourself. Like it really takes you a long way, right? Then we come to medication management. And I'll stick to mostly the antidepressant use, right?
Mm-hmm.
So if a person, if the mother is already on antidepressants because of depression in pregnancy, then it's just wise to just continue
Okay.
on the medication, right? Antidepressant, basically. If there is a prior history of depression and there is adequate response to that, there is adequate response to an antidepressant trial, go back to that same medication. Don't try anything new. Starting on a new antidepressant, if the mother has never tried any antidepressant, then you can start on a new antidepressant, and that's okay. Always target the lowest effective dose, right? So that's important. So here, the concern that mothers have is, oh, am I exposing my baby to the medication, right? So there are certain things that we need to clarify here. So antidepressant use in breastfeeding, right? So infant exposure after childbirth, right? After childbirth is way less than in utero exposure. So that is something that we need to understand. So if a mother is already on a medication and she has the baby, it's okay to breastfeed, right? And it's generally safe. Now there are some exceptions, like, if there is a premature baby, if there is low birth weight, if there are complications in the child, then we need to consider some options here as to we don't know if the newborn would be too sensitive to that little exposure to an antidepressant through breast milk, right? At that point, we can consider. And if we are using other medications other than antidepressants, the regular antidepressants that we use for depression, like we use CNS depressants, or we use some sleep aids and stuff, then we need to be careful. But this should be safe. Consideration when treating depression should be given to the severity. If it is so severe, then here is what can happen, right? If we don't, I wanted to go to this slide here. Untreated postpartum depression. It is something that we need to understand. It can, if postpartum depression is significant enough and is untreated, it can impair the bonding between the mother and child. It can lead to suboptimal parenting, where there can be a little bit of neglect or at a minimum, or suboptimal care, or low frustration tolerance, a tendency to give harsh punishments. That can have all that, just not interacting with the baby as much. It can cause some cognitive delays in the baby, or subsequently too. And subsequently too, it can cause behavior problems. So that is why it is important that whether it is through medication or therapy or something, the depression needs to be treated.
You explained it very well, the way the depression can affect during the pregnancy and after the delivery. And at the same time, sleep, as we all know, sleep will be we know that you are double certified in both sleep medication, sleep medicine, and and psychiatry, and we know that the sleep will be equally disturbed after the delivery, taking care of the baby and the hormonal changes. So can can you educate us more about the sleep disturbances after the delivery and how the sleep hygiene can be improved after the delivery and how the other people can help her?
So there are a few things to understand here. So we all know that, we mothers know that during pregnancy, sleep is not the greatest for various reasons, right? And then we have the baby and sleep gets even worse. Um, However, sleep is important. Sleep, sleep is important. For us to be able to sleep, we will need to prioritize sleep. So, meaning we give it enough importance. If we are sacrificing our sleep over, oh, the baby is sleeping, so let me go do household work, then we are depriving ourselves of the much needed rest. And sleeplessness for significant period of time can also be a risk factor for depression. So, and there are so many reasons. Like, I'll just give some examples here. Uh, New mother on maternity leave, not working, not making the money, um, feels obligated to take care of the child day and night because the spouse is hardworking, which is, I don't refute that, right? Or the spouse has to make the money or whatever. Oh, I need to be able to take care of my baby, all that. So all day and all night, it continues. Is just getting chunks of sleep at night, and during the day there are household duties. The thing that happens with newborns is newborns don't have a circadian rhythmicity, right? And everybody who has had a newborn knows this. So sleep is all over the place, feeding schedule is all over the place, bowel movements, all that is all over the place. There is no rhythmicity um, to the newborns' activities. So that has a heavy impact on the mother. So then how in the world can the mom get some sleep? So prioritize. So you suppose say uh, sleep is so disrupted and you can't do much about it. So align your sleep schedule with your baby's. Whenever the baby is sleeping, you sleep. Whether it's during the day or night, it's a matter of just 1 month. You just plow through, make sure that you get some sleep, some rest here and there. Just align it with your baby. Understanding that it's not possible to nap every time the baby naps during the day because there are other household works, but you can grab a nap, that's okay. I would say that's okay, even though I'm a sleep specialist. It's all over the place, sleep hygiene. Oh, don't take a nap. The first 1 to 2 months after childbirth, I'm not going to argue about it. Just get some rest. That's important. And if you can, please rope in family, please rope in your spouse. If you're very tired, just give yourself some rest. Just take a break.
So
Avoid sleep aids. Yeah, go ahead.
with all these things, is it okay uh, if all these efforts, if she is not getting enough sleep, is it okay for her to take medications for sleep?
So, and this is also a very, very important question, Pushpa. So we have to look at the vulnerabilities, the some predisposing factors, in other words. Like if there is a prior history of some serious mental health condition, or there are some like risk factors already. If there is usage already of some psychotropics that can cause sedative side effects, suppose say, just for example, So, I mean, so there are some vulnerabilities that have to be considered. And your specific question is it okay to take sleep aids? So when it comes to taking sleep aids, this is not my general recommendation. This is not part of my usual recommendations to say it's okay to take medications for sleep. I usually recommend not to, especially um, for mothers who are breastfeeding, even otherwise, because even as simple as over-the-counter medications can affect um, the cognitive state of mind, can affect um, your alertness, even during the day or at night. I mean, you might not be able to wake up if the baby needs you. We don't know. Like, I usually tell people to avoid. Again, we look at what the concerns are. It is important to get sleep, but it is also important to accommodate the fact that it's not going to be ideal sleep. Not having the best sleep is only normal during postpartum phase. So you manage until the baby circadian rhythm sets in. And there are ways that you can help to uh, uh, to regulate the circadian rhythm of your baby, like having consistent timings with feeding schedules, with bathing schedules, um, having consistent bedtimes, wake up times for the baby, consistent nap times, things like that. It can be regulated. The first couple months is difficult, but after that, it is possible to regulate a baby's circadian rhythmicity and have some predictability there. So you can align your sleep habits accordingly.
Thank you so much for all the discussions. And you have some questions from the audience?
Okay.
Can Deepa read those questions?
Yeah. First one is, yeah, pregnancy is a happy pampering phase, right? So will women tend to have depression during pregnancy? Is there a possibility?
Yes, it is a possibility. And there are, again, reasons can be various. There can be some genetic reasons to like psychosocial reasons, socioeconomic reasons. It is possible, very much possible to have depression. I don't think women get as pampered as they think they do.
Yeah. Question, meds during breastfeeding.
Medications during
Yeah.
breastfeeding.
Can they
So
take medications during breastfeeding?
antidepressants are fine. And as long as it's the target dose is the lowest effective dose, as long as uh, consistent efforts are put in to avoid polypharmacy, um, as long as CNS depressants and benzodiazepines, overuse of benzodiazepines are avoided, regular antidepressant use, that's fine.
Yeah, Jaya is saying she's going to send this link as the best baby shower gift.
What?
Jaya is saying she's going to send this link as the best baby shower gift.
Oh, that's so nice. Thank you. Appreciate it.
Yeah, is there any questions on the, yeah, there are a few participants. Do you have any questions? No.
I would just like to say one more thing here. Going back to the severe depression with psychotic features, in that case, the medication management changes. So it's not just a regular antidepressant that can help overcome that. There needs to be an additional usage of an antipsychotics, let's say. And antipsychotics can impact the cognitive state of mind, alertness of the mother and all that. So all that will need to be taken into consideration. If high doses are needed, then maybe there might be a need to transition out of breastfeeding.
And also, I have a question. Like, apart from these medications and treatments, like, should women prioritize her me time during this phase to avoid depression?
Yes, so it's absolutely important. Even though there is no such things like preventing postpartum depression, but these things do help a lot. And every mother should make an attempt to just take a break.
Mm-hmm.
Mm-hmm.
So we are coming to the end of this session, and thank you so much, Dr. Kamala Audury and Pushpalatha Venkataraman, for taking time out of your busy schedule to talk about this important topic. And thank you for the
Thank you.
participants who attended.
Thank you so much. It has been a privilege. I really appreciate you considering me for this talk.
Thank you so much
Thank you
for
so
the opportunity. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.